Hi guys, welcome to Radiology 365, where we try to cover core radiology from cover to cover. Today we are going to be talking about malignant hepatic masses. This is going to be a little long, but bear with me. So let's begin by understanding how hepatocellular carcinoma develops, especially in cirrhotic livers. It's a stepwise process from regenerative nodules to dysplastic nodules and finally to full-blown hepatocellular carcinoma. This progression reflects increasing cellular atypia and angiogenesis, as we can see the neovascularity that occurs during the hepatocellular carcinoma formation. The challenge on imaging is that these stages can look very similar, especially when comparing high-grade dysplastic nodules and well-differentiated hepatocellular carcinoma. Our role is to recognize key imaging clues that hint at malignant transformation early enough for effective intervention. Regenerative nodules are benign formations that occur as a result of liver regeneration in cirrhosis. These are not pre-malignant. They retain portal venous supply. The liver is mainly supplied by the portal vein. So the fact that these regenerative nodules still maintain portal venous flow makes them more benign, and they do not develop neovascularity. On MRI, they usually appear T2 hypointense and may sometimes be T1 hyperintense due to glycogen or copper deposition. Importantly, they are typically iso or hypoenhancing relative to the liver on contrast imaging, helping us distinguish them from lesions like hepatocellular carcinoma, which would be hyperenhancing. Because of the neovascularization and the angiogenesis that occurs, HCC would take its blood supply from the hepatic artery as opposed to normal liver parenchyma taking bulk of its vascularity from the portal vein. So these images show a dominant regenerative hepatic nodule, and A is pre-contrast, B is late hepatic arterial phase, and C is a portal venous phase. D is a fat suppressed single shot fast spin echo T2 weighted image. And we see this subcapsular partially exophytic nodule at the hepatic segment 5, which demonstrates increased intrinsic T1 signal. You can see it's a little bright on T1 on the pre-contrast image, and it shows iso signal intensity to the background liver on post-contrast image here, and here. So even when we look on the late arterial phase, it doesn't show marked contrast enhancement, still getting a little iso to the liver, also owing to its very low signal intensity on T2. All these findings put together point to a dominant regenerative nodule. If it were HCC on the arterial phase, it would pick up the contrast very brightly, which it did not. So that makes us relax. Dysplastic nodules bridge the gap between benign and malignant. These are pre-malignant lesions, especially the high-grade ones. They are still supplied by the portal vein primarily, but you may occasionally see some arterial phase enhancement, especially when they are high-grade. So the high-grade dysplastic nodules are moving a little more towards malignancy, and so they may have arterial phase enhancement. That enhancement without washout is a red flag. On MRI, they are often T2 hypointense on T2, just like the regenerative nodules, though their appearance can be variable. Recognizing these can help us flag early hepatocellular carcinoma transformation. So as we can see in these images, we have on this late arterial phase a focus of enhancement in this liver, this arterial phase enhancement in this liver, which made us worry a little about a regenerative nodule. Then we have siderotic nodules. Siderotic nodules are regenerative nodules or dysplastic nodules that have accumulated some iron. They appear dark on T1 and dark on T2, especially T2 star sequences, because of the ion and the way ion distorts the magnetic field. On CT, they show up as hyperdense nodules due to the ion content. Although they are rarely malignant, they can sometimes confuse the picture. So it's good to be aware of this subtype of nodules. Ion sensitive sequences like gradient echo can be particularly helpful in identifying them. It's important to remember that ion within a nodule makes it very, very, very unlikely to be malignant. Okay, so these images show multiple hepatic nodules on the in phase and out of phase sequences. We have these multiple nodules which are barely perceptible on the out of phase image and tend to drop signal on the in phase, characteristic of siderotic nodules. HCC is the most common primary liver cancer and arises predominantly in the setting of chronic liver disease, especially cirrhosis. Hepatitis B, hepatitis C, and non-alcoholic fatty liver disease are significant risk factors. The classic teaching is any hypervascular liver mass in a cirrhotic liver should be considered hepatocellular carcinoma until proven otherwise. Alpha-fetoprotein, although not universally elevated, can support the diagnosis in around 75% of cases. Our goal in imaging is early identification when treatment options are more effective. For patients at high risk of developing hepatocellular carcinoma, such as those with cirrhosis or chronic hepatitis B, regular screening is crucial. We usually start with alpha-fetoprotein and ultrasound every 6 months. However, ultrasound becomes less reliable in a nodular cirrhotic liver and its sensitivity decreases. MRI is increasingly used in such a case, especially when the nodules are detected or suspicion is high. The goal is to detect HCC when it's less than 2 centimeters in size, because at that stage, patients have more curative options. When it comes to imaging diagnosis of HCC, we look for a set of characteristic features. The most important is arterial phase enhancement. This occurs because HCC develops its own neovascular supply. This is followed by washout in the portal or the delayed phase, which reflects the lesion clearing contrast faster than the background liver. A capsule appearance enhancing on delayed phase adds to the diagnostic confidence. On MRI, they often appear T2 hyperintense and show restricted diffusion. The nodule-in-nodule pattern, where an HCC arises within a dysplastic nodule, is another useful clue of early transformation. So in these images, we have a large fat-containing hepatocellular carcinoma. A is an in-phase and B is an opposed phase image. C is a gradient echo T1 weighted pre, and D is a post-contrast fast suppressed 3D gradient echo T1 weighted image during the late hepatic arterial phase. And there is a prominent left hepatic nodule which demonstrates minimally increased intrinsic T1 signal. It's minimally increased here, as seen with the arrowhead, and low signal intensity on the opposed phase. So it has a signal drop on opposed phase, indicating some intracellular fat component. The lesion demonstrates heterogeneous, mildly increased arterial enhancement. That's on the D image, and all these put together with this mild arterial enhancement are all in keeping with a fat-containing hepatocellular carcinoma. One of the more aggressive features of HCC is its tendency for vascular invasion. It can invade the portal veins, hepatic veins, or even extend into the IVC. When you see a thrombus in a vein with enhancement similar to a hepatic mass, think tumor in vein. This has major implications for staging and treatment. It's also one of the key differentiators between HCC and metastasis, which usually do not invade vessels in this way. So this image shows a tumor thrombus from HCC within the middle hepatic vein extending into the IVC. You can see this lesion within the middle hepatic vein extending into the IVC, which enhances very similar to the hepatic mass. This was a tumor thrombus in the middle hepatic vein in the case of HCC. The Liver Imaging Reporting and Data System, LIRADS, was developed to standardize reporting in patients at high risk for HCC. It helps reduce variability and improves communication between radiologists and referring physicians. It categorizes lesions from LIRADS 1, that's definitely benign, to LIRADS 5, definitely HCC. The major imaging features we rely on are the same ones we've discussed: arterial phase hyperenhancement, washout, capsule appearance, and growth over time. If you are ever unsure, remember that ancillary features can help nudge the category, but they don't override the major features that we have discussed. If you have found value from this, give it a like, comment, share to someone you think would love this, and I will see you in the next one.